In this session, I would like to walk you through a structured and clinically oriented approach to liver ultrasound, focusing not only on image acquisition but on interpretation and diagnostic reasoning in daily practice. When we perform a liver examination, the key word is systematic. A comprehensive evaluation requires both sagittal and transverse planes, ideally during deep inspiration to optimize acoustic windows and improve visualization of the dome and posterior segments. I always recommend starting with a reproducible landmark. The inferior vena cava is an excellent reference structure in the sagittal plane. From there, we can systematically explore the right lobe from medial to lateral and craniocaudal, then proceed to the left lobe. Maintaining a consistent scanning method reduces the risk of missing focal lesions and improves interoperator reproducibility. From a parenchymal standpoint, we assess echotexture, homogeneity, and vascular architecture. In normal conditions, portal vein branches are typically surrounded by a hyperechoic wall due to the fibrous and biliary structures in the portal triad, whereas hepatic veins usually have thinner, less echogenic walls. Recognizing this distinction is fundamental in segmental orientation and vascular mapping. And next, we evaluate liver size and morphology. Although measurements along the mid-clavicular line has historically been used, it has limitations due to the respiratory variability and anatomically differences. More reliable indicators include the morphology of the inferior margin. Normally, the inferior border of the right lobe is sharp, with an angle below approximately 45 degrees. Rounding of this margin may suggest hepatomegaly or congestion. Similarly, the lateral margin of the left lobe should be acute. Blunting may reflect pathological enlargement. In the transverse subcostal approach, especially on the right side, we can effectively evaluate the confluence of the hepatic veins into the inferior vena cava. In normal conditions, the peripheral diameters of hepatic veins should not exceed 6 mm. Dilatation, particularly in association with an enlarged inferior vena cava and reduced inspiratory collapse, raises suspicion for right-sided heart failure. In advanced cases, we may also detect pleural effusion, adhesion to the diaphragm. Moving to parenchymal diseases, steatosis is one of the most frequent findings. Diffuse hepatic steatosis results in increases echogenicity compared to the renal cortex. In advanced stages, ultrasound attenuation limits visualization of deeper structures and posterior beam penetration is reduced. It is important to recognize that steatosis may also present in focal or multifocal patterns, which can mimic metastasis. In such cases, the absence of vascular distortion and the typically distribution patterns help guide differential diagnosis. Anatomical variants must also be considered. Diaphragmatic impressions and pseudolesions caused by muscular slips may simulate focal pathology. Recognizing their location and behavior relative to respiratory movement prevents unnecessary alarm. Simple hepatic cysts represents common benign focal lesions. Their diagnostic criteria are well established: anechoic content, round or oval shape, thin regular wall, posterior acoustic enhancement, and well-defined margins. Any deviation from this pattern, such as an internal echos or septations, requires further characterization. Parasitic cysts, such as echinococcal lesions, demonstrate a spectrum of appearances depending on stage, from thick-walled cysts to daughter cysts and detached membranes. These findings require careful evaluation and appropriate clinical correlation. Hemangiomas, the most frequent benign soddy lesions, are often hyperechoic and well-defined. Their vascular behavior, especially when contrast-enhanced ultrasound is used, typically shows peripheral nodular enhancement with centripetal fill-in. This pattern is extremely helpful in distinguishing them from malignant lesions. Focal nodular hyperplasia may appear isoechoic or mildly heterogeneous and can displace adjacent vessels. In selected cases, contrast studies reveal a characteristic central scar with radiation vascular patterns supporting benign diagnosis. In cirrhotic patients, systematic screening is essential. Cirrhosis leads to surface nodularity, heterogeneous echotexture, altered vascular architecture, and signs of portal hypertension. In this context, early detection of hepatocellular carcinoma is critical. Suspicious lesions often show arterial phase hyperenhancement followed by washout in later phases on contrast-enhanced studies. Finally, metastases may present with variable echogenicity. Hypovascular metastases, such as those from colorectal carcinoma, frequently demonstrate early washout in the portal venous or late phase, appearing hypoechoic relative to the surrounding parenchyma. Understanding vascular behavior is essential for differentiation between benign and malignant lesions. In summary, liver ultrasound is not merely a technical examination. It is a dynamic process integrating anatomy, hemodynamics, and pathology. A structured approach combined with solid knowledge of vascular patterns and parenchymal behavior allows us to provide high diagnostic value in both routine screening and oncologic follow-up. This is the foundation of an effective and clinically meaningful liver ultrasound assessment. Thank you for watching.